You know, it's no coincidence that the most urgent mental health issue is also the one that's most difficult to discuss. That's because over the years, there's always been a stigma attached to suicide. It's almost as if just saying the word gives the act itself more power. But as always, we need to talk about it, and that's what we'll do today. And we'll do it with Dr. Michael Miller. He's an assistant professor at the University of Minnesota and also a therapist, and his focus has been on personality disorders and suicide for the last 20 years. You know, you don't look that old, but that's what you told me.
That is. Thanks, Mike.
So why don't we get started with you just telling us what you do and how you do it.
Okay. I'm a psychologist in the University of Minnesota Psychiatry department, and in our department we have a program called Dialectical Behavior Therapy that primarily focuses on individuals with personality disorders as well as individuals with a history of self-harm and suicidality and suicide attempts.
And the age group you work with?
Primarily about 15 to 25. I have two different groups that I run there as well as sort of individual therapy and supervision. So,
in recent years, probably in the last 10 years from the statistics I've seen, that's an age group which has been especially prone to suicide. Is that something you find to be true?
Yeah, actually the most recent data is showing that there's been an increase in even the younger ages, even down to say 12 and 13. Relatively speaking, there's a lot of suicide attempts between the ages of 15 and say 18 to 21. Adolescent females have the most suicide attempts, but the fact that it's shifting to younger and younger ages is definitely more concerning for us.
And why do you think that is? Why that shift?
The data doesn't really show specific reasons. I think if you look at sort of anecdotally in terms of what we're seeing in our communities, middle school is becoming much more challenging for individuals. There's a lot more bullying. You know, there's a lot of environmental factors that seem to be increasing the level of sort of volatility for adolescents and even sort of those preteens. Social media continues to be a challenge with bullying both in the school as well as electronically. And, you know, then we're still talking about individuals with lethal means. And that's one of the things we talk about all the time with any of our clients is sort of where is the lethal means, and if they've got access, then that always creates a problem.
When you say lethal means, explain that.
Well, when we talk about lethal means, Mike, we mean anything that someone might actually use to kill themselves or harm themselves. And the reality is, with the internet, you know, I'm not going to go through the list because that would probably be inappropriate, but the reality is it's not as simple as what we used to think, you know, okay, they're going to use a gun, they're going to hang themselves. There's a plethora of different things that are out there on the internet, and you can go and find Reddits and websites that are actually going to direct you as to what's the most effective way to commit suicide.
I guess that's something you just can easily Google and you can figure it out quickly.
Exactly.
What about the impact then of social media? I mean, I can see where it could be positive in some ways, but I gather maybe not always, maybe not usually.
Yeah, the biggest challenge I think with social media, it's sort of, I liken it to the shift that we saw, and I think a lot of parents will get this, the shift that we saw when people moved away from typewriters to computers. The minute you got a computer in your hands, now everything had to be perfect. If there was a typewriter, if there was a typo, that's what we called it. You erase it, you use it, you know, there's some way you correct it, but nothing was ever going to look perfect. Well, with social media now, I can take 5 photos of myself at the state fair. I'm going to pick the best 2 photos, I'll send them to my friends, and eventually those friends will say, that's the best photo, and that's what I'll post on Facebook or Snapchat.
Sure.
And after I post it, I'm waiting to see how many people respond. So it's the immediate sort of response. If I don't get 30 or 40 of my friends to actually like or respond to a photo I posted 15 minutes ago, that automatically sort of creates this intense angst and almost sort of rejection that just wasn't present, you know, 15, 20 years ago.
You told me, we were talking about this the other day, and you told me that kids at risk know almost instantly when someone in their age group and who lives nearby takes their own life.
Yeah, actually, I mean, you'll see it, it'll be posted on Facebook. There will be, you know, individuals will respond immediately to a Facebook post. it's not uncommon for it to sort of spread throughout, you know, their community, their social network, through Snapchat, through Reddit, showing up at the high school or middle school. It's pretty prevalent, and it happens very quickly.
Yeah.
And I know frequently the concern in the community is that there's going to be a contagion effect when that happens.
I think that's something that all parents worry about. And as I said, you know, in the introduction, you worry that just talking about it makes it more likely to happen. And I know that a lot of parents, well, not just parents, friends, loved ones, are very reluctant to bring up the subject, to ask a friend, a family member, a child, if they're thinking about suicide, because they just don't want to. It's almost like they think it's like planting the idea in their head.
Yeah, and that's probably one of the biggest misnomers, and not just in lay people, I think professionals as well. The idea that if I actually ask you if you're suicidal, that's going to cause you to feel suicidal. The reality is, for individuals who struggle with suicidal urges, ideation, you know, the only challenge is sometimes they might get an idea of how to do it if someone's being really specific. But the reality is, if they're feeling suicidal or they're having the thoughts, ask them.
Yeah.
Because what we know about suicide, and you sort of said this in your intro, there is this stigma around it that we just don't ask. And, you know, one of the things I think sometimes becomes the challenge for family members, but also for professionals, is if I ask the question and they say yes, then what do I do? And there's almost a fear of, if they say yes, I'm not sure where to go next.
Right.
And I think that frequently becomes the challenge.
Well, I guess then you've kind of posed the next question. What do you do?
Well, I think there's lots of options, believe it or not. You know, resources are always stretched, and that's not uncommon, even here in the metropolitan area. But the reality is, there are things like, I mean, even First Call for Help. You can look out to NAMI. You can look to the United Way has a website as well as a phone number. There are lots of options for resources. I mean, if you really feel like someone that you're living with or someone you're dealing with is suicidal, you take them to the emergency room.
Right.
The physicians there, the nurses there, the social workers are well trained at identifying sort of what the warning signs are and also what the severity of their thoughts and thinking is. I never would want a parent to feel like they've got to handle it on their own.
And I know from talking to some friends that who have taken, in many cases, taken their kids repeatedly to the ER, it can be very hard, however, to get them admitted because there's not that much room.
Yeah, I mean, the shortage of beds is frequently a problem when it comes to individuals, especially adolescents and children. And the thing that I think is hard for people to understand about individuals who are suicidal is, while we don't want to turn people away who are suicidal, the reality is, for a lot of individuals who have suicidal thoughts, being in the hospital isn't always the best fit for them. You know, when we talk about sort of what to do for individuals with suicide, we really think about the personalized intervention and what's the best fit. And as crazy as it sounds, you know, sometimes the best fit for the kid and for the family is a mom or a dad sleeping on the floor in the bedroom, because it's certainly been done. And I think, you know, that's sometimes, I think the challenge is, it's not a one size fits all.
I know you do personal as well as group therapy, and I wonder if you can tell me about some of the techniques involved. I know that you do what's called DBT, Dialectical Behavior Therapy. I can't even say it, let alone do it. but I know what it is, and a little bit, but I'd like you to explain it more.
Well, DBT was started by a woman by the name of Marsha Linehan, and her story is actually pretty well known. There was a New York Times article that she actually sort of discussed some of her own challenges as a teenager, young adult. She revealed this actually at a hospital, an inpatient hospital that she had been as a patient when she was growing up. But she came up with this cognitive behavioral treatment that really is focusing at its simplest core on deficits. It's a recognition that for whatever reason, some of us don't have the same skill set, particularly around areas of like emotion, interpersonal skills, and even just sort of the idea of how do I keep myself safe. Individuals with borderline personality disorder, and it's sort of been expanded beyond that, really struggle with this idea of once I'm hurt, once I'm upset, my emotions get so intense that I don't know how to regulate and bring myself back down. And that's a lot of what DBT does. It helps around the emotion regulation. And in the short term, quite honestly, we work on just keeping people alive.
So how do you do that?
A lot of it is about specific skills that we do teach in DBT, and a lot of it is also relationship. It's relationship with the therapist, it's relationship with other individuals around them. One of the strongest protective factors we have for people who are suicidal is not feeling isolated. So it's, if the family's estranged, how do we pull the family back in? How do we pull in your siblings? How do we pull in maybe aunts and uncles that you don't normally even think of to be part of your safety network?
And of course, people who are depressed isolate themselves. I certainly know that was true of my brother who killed himself probably 20 years ago, and it was hard to get him out of the house, sometimes for weeks and months at a time. And obviously you get into that vicious kind of cycle there.
Right. I think that's where you have to get creative, and as professionals we are getting more creative, and I think even extending the limits of, we talk a lot about HIPAA in terms of compliance and making sure that we're not discussing other individuals' sort of case, if there's a child involved, we don't talk to the parents unless we have release, depending on their age. But one of the things that we've started doing more of, and DBT does this, is we do what we call phone coaching. So we'll actually have crisis calls with our individual patients. There's a lot of telemedicine happening in rural areas, in rural Minnesota. And so even when you're saying your brother wouldn't get out of the bed, the reality is I have a colleague who has done video conferencing for individuals she's had in her DBT group. And I think it can be really effective and certainly an innovative way to sort of reach more people.
Just going back to something we talked about before, and that is this phenomenon that I think terrifies parents of copycat suicides. For example, there's the Netflix show, 13 Reasons Why.
Yes.
I think it's settled down a little, but I know a lot of parents were freaked out about that, and they were afraid that if their kid watched that show, they might try it. I mean, is that a real thing?
Well, I think, again, Mike, what we're talking about is individuals who are already thinking about it.
Yeah.
And I think that's really the key is when we're looking at things like the show 13 Reasons Why, we're looking at individuals who are already going to be vulnerable and at risk, right?
And they'd be drawn to the show, of course.
They'd be drawn to the show, but if you're a high schooler who isn't really thinking about suicide, that show is probably not going to have a huge impact on you. If you're a middle schooler who's still trying to figure out where you fit in, and you've been struggling, that can have a much more, they're much more formidable years and can be a little bit more impactful. So the reality is, we do definitely look at shows like that and consider, okay, how impactful is that going to be? I can say that for most of the patients I work with, the most impactful thing about that show was not actually her suicide, but it was actually some of the sexual assaults that occurred in conjunction with that. I think that was probably more disturbing and distressing for the individuals I work with.
So typically I would assume that the first person you talk to, with especially the younger people, would be the parents. And so how do they get to you, and what do you say to them?
Well, usually, most of our referrals, especially for me, are coming through our department. It's frequently they're seeing somebody in our clinic, or they call our clinic at the psychiatry department. The conversation I usually have is sort of where exactly is their child at in terms of behaviors and severity. And then I really do a lot of educating. We are a small program. I feel very strongly about what we do, but we don't have the capacity to treat everyone. So I do my best to make sure that I educate people on what they're looking for in terms of treatment and providers.
So we all know that the biggest, most important symptom is just depression. And I think that a lot of parents are aware of kind of what to look for there. But what are some of the other markers?
Well, I think the other things you're probably looking for with somebody who's suicidal is, you're also looking at sometimes, checking the internet history to see what they're searching. You're going to look for the continued depression is one thing, but the hopelessness is what really starts to get, that's one of those factors that really has a huge impact on individuals.
Sure.
Increased isolation. There's this big word we call anhedonia, but really it's a fancy word for saying I lose interest in the things that I normally have interest in.
Right.
So
you start wondering why it is you do something. Like you start questioning.
Right.
Sometimes it happens with just like a midlife crisis.
Right.
But of course, I saw it with my brother. Was helpless to do anything about it. But I definitely saw that with him. I think that was probably in that case that for him that was the most alarming thing. And as you say, I guess that just goes with hopelessness.
Right. And you want to look, especially with teenagers, you look at the things they're interested in terms of sports or activities. Because when they're really struggling, those are the things that they're going to stop doing. They're going to say, well, I'm not interested in doing softball this year. I'm going to drop ballet. And so really paying attention to those things. Yeah. And the things that really bring them joy historically, if there hasn't been a significant sort of disappointment, that's usually an area that I would look at and sort of highlight for family members.
One issue that I'm always interested in, I guess because of the important impact in my own life as a depressive, is the use of medication. I read a lot of stuff these days saying, antidepressants don't work, they turn people into sociopaths. Kind of makes me angry because I'm just afraid it would turn people away from something that they really need as a lifeline. What's been your experience?
Well, being in the psychiatry department, the wonderful thing about where we are is we actually have a very nice balance. Our department chair is she advocates quite a bit for mental health sort of interventions that don't include medication. It's not sort of a one, take a pill and we're done.
Oh, right. Yeah.
So we have really expanded that more and more within our department. When we think about it, or at least I think about it, what I think of is it's sort of like driving in Minnesota weather with 4-ball tires. If you're not on medication and you're really struggling with your anxiety, your depression, it doesn't matter where you're trying to turn that car, whether you're trying to go faster or slower, your car's going into the ditch because you're on 4-ball tires. Now, if I have you in winter weather and I also put steel-belted radials on, i.e. sort of a medication, you're still deciding where you go. You're still deciding whether you go left or right, forward or back. But you can actually make that choice. And the biggest challenge, I think, for a lot of people with severe depression is that they don't feel like they have the ability to make the choice.
It's just been a few days since the massive demonstrations in Washington and around the country, the response to the Parkland shooting and demand for action. I wonder how that's processed by vulnerable kids.
I think what happens is when there are those sort of tragic events, it definitely has an impact on individuals who have either probably had some trauma in their own history or just don't really feel connected to the environment. And it certainly increases their level of sort of anxiety and fear, which is probably going to worsen their depression. I think seeing their peers do something about it, I think actually is more hopeful.
Yeah.
I think the unfortunate thing is that's probably still going to be somewhat limited because it's not right here, it's not in their neighborhood, and they still have to go to school tomorrow and kind of deal with some of the all the same changes and challenges they've had up until this point.
Is that something that kids talk about in therapy?
Oh, definitely. I think it's, the fears around sort of their safety at school, but also fears around, it's not just sort of dying in school from a shooter, it's the bullying and sort of, being ostracized by their peers. I mean, you have to still remember that the folks I usually work with are the teenagers, and they have a tendency to still be very sort of narcissistic in their approach to their world at certain times.
I guess maybe I tend to think way too much of gender identity as being something that's a settled issue because we've made progress in that area. But maybe I assume too much. I guess kids are always going to struggle with that.
There's been some studies, and it's sort of controversial as whether or not gender identity or anything around that actually increases your risk. I think what really increases the risk for suicide of teenagers in general is not so much what I'm struggling with. A lot of times it's how my family and my environment responds to that struggle.
And you talked the other day about family isolation. I wonder if you could explain that.
I think what happens a lot, especially with someone with major depression and making suicide attempts or having suicidal ideation, is the patient becomes the focus. And the reality is the patient lives within the family system, and the family ends up feeling incredibly isolated. And there's some really great data that actually highlights the fact that the more stress the family experiences, the more challenges the patient or the identified patient experiences. So they sort of feed off of each other. And if we can get more interventions for the family and help them understand, it really can actually make a huge difference for the individual who's struggling with depression and suicide.
So when you talk about the family struggling, are you talking about the relationships within the family or economic issues, or I guess there's a whole basket of them.
There is a whole basket. If I were to keep it specific with suicide, the reality is repeated trips to the ER, repeated trips to physicians, therapists, failed therapies. The family members who are caring for the individual are incredibly stressed. We've seen actually some data that supports the fact that approximately 1/3 of most of those caregivers are suffering from major depression themselves. And so helping the caregivers feel like they actually have support and aren't isolated themselves, because this isn't something you talk about at work. This is not something you just kind of pull in someone at the lunch table and say, hey, let me tell you about my kid who's struggling with depression and I took him to the ER.
Right.
I hear that repeatedly from families that I work with.
One of the things that I noticed after my brother killed himself, that a lot of the people in the support group, I went to a support group, through SAVE, which is a great organization. But one of the things I noticed was that obviously this is something that tears people apart anyway, but it was even harder for family members to struggle with because probably the depression was in the family and they suffered it too. So they were, they had even less tools to try to deal with something like that.
Yeah, the challenge is not just the fewer tools. If you're the family member who's been treating or kind of been around for that individual, the odds that that's probably the first time they made a suicide attempt are pretty rare.
Yeah.
And so the reality is a lot of those family members that you were probably meeting have PTSD or post-traumatic stress disorder themselves.
Oh, absolutely.
Simply from caring for their loved one.
Yeah, there's no question about that. And with that, and I guess you probably deal with, you also deal with people who are what we call survivors of suicide. And these are people who feel guilty, these are people who are angry, these are people who are depressed. I mean, it's just a mess, but I will say this, the human spirit is an amazing thing. And I've seen people claw back from that, not all the way, but I've seen them claw back, and so that's one thing that's hopeful, and I'm sure you see that too.
Minnesota has an amazing NAMI organization. It's the National Alliance for Mental Illness, and it is a grassroots organization. It is certainly supported by professionals, but is not run by professionals. It's families, and it's all about sort of supporting the families, and they have amazing like SAVE, they have amazing programs that are set up to help families not feel isolated and pair families up with groups or even individuals who can help them sort of wade through that sort of mess.
So before we wrap up, I'd like you to take a look back. 20 years it's been, and I know you've seen a lot of changes. I wonder if you could just trace some of those steps and just give me a few bullet points there.
I think that, in the last 20 years, even though DBT is not a suicide prevention program, and Marsha Linehan will say that very clearly, it really has made a big difference in how people approach suicide and suicidal individuals. I think that has probably been the biggest seismic shift, is that there's much more awareness now than there used to be, and I think we're really still making the shift to improving our interventions. I think the area that we still struggle and probably is sort of the big gap, is the area of supporting the families. And I think that's the thing that we would, as professionals, I think we fall down at it. I don't think we involve families as much as we can. But I do think that, DBT in conjunction with some of the pharmaceuticals that are now available that really continue to refine sort of the ability to deal with people's depression has made a significant impact.
And yet, the suicide rate just keeps going up. Is some of that just the fact that we now know more? It's traditionally we talked about the stigma, and I'm pretty sure that over the years, a lot of people who have taken their own life, that's a statistic that really never gets recorded. You see the obituaries, it'll say, after a brief illness or suddenly, and you kind of read between the lines,
Right.
I know, but I'm just wondering if that's part of it.
What I would say is, there's a part of what's going on in our society. The highest rates of suicide have always been in actually older males,
right?
55 to 65. That's actually moving down a little bit in terms of age range, but continues to go up in terms of numbers. And it's baby boomers who are really reaching retirement age and really, seem to be struggling with some of the physical limitations that they're experiencing. I don't know that we have a really good answer for that at this point, but I do think that there's also that factor that you're talking about in terms of we're much more aware and we really are paying attention. And I think, there was a young man who committed suicide out in Stillwater, and his family did an amazing job of really being open and honest with the community, and it was pretty astounding to see.
We hear more and more that suicide, maybe what I should say is there's more awareness that suicide is a disease of despair. And so there almost has to be a correlation between economic factors, recessions. We know that wages have been stagnant for workers for many years, so there is more economic pressure. There is, I think, for political reasons, for social reasons, there is that feeling of hopelessness that it just seems to be something that seems to be spreading a bit. My assumption is that correlates to a rising suicide rate.
Yeah, I don't know if we have anything that really is going to connect directly to what you're describing, Mike, in terms, I get what you're saying with the hopelessness. What we do actually have data on is, homeless youth. There's definitely a colleague of mine at the university actually just finished publishing from some data that they had in regards to the increased incident rate for suicidal teenagers and adolescents. And, not really a surprise in some ways, but kind of speaking to what you're saying, if I've got to worry about all these other factors, it really does make me more vulnerable than sort of the rest of my peers.
What advice do you give to people watching this show, especially parents? They're seeing that there's a problem. What do they do right now?
I'm a professional, so I see a lot of teenagers, but the reality is I don't see your teenager. And your teenager. And so as far as I'm concerned as a professional, if you as a parent are really concerned, then I think there's a reason to be concerned. I don't think it's a random sort of, I trust that sort of gut instinct that parents have about their own children. And that's where I think you just go and ask. I think you ask them directly. You ask them how they're doing, even if it seems uncomfortable, even if you're terrified of the answer. But asking directly so that they know. It's sometimes the most validating thing for a teenager is to ask them something directly and just say, are you struggling with suicide? Have you thought about this? And take the conversation from there.
Well, I guess that's why we call the show We Need to Talk. And with that, Dr. Michael Miller, it's been great to have you with us today. It's been a brisk conversation. We Need to Talk, brought to you by the St. Louis Park Mental Health Action Committee and the folks from Southwest Community TV, from Hopkins, Eden Prairie, and Minnetonka. We Need to Talk. In future episodes, we'll be discussing just about anything related to our mental health as we seek to raise awareness and suggest pathways to healing. But no matter what the issues, the first step is always acknowledging the problems and understanding that help is available.